The biggest cognitive dissonance right now is that at the same time that you've got papers published that show that AI can have superhuman physician performance on taking histories and, coming up with differential diagnoses and coming up with treatment plans, you also have literature that shows AI, even the most advanced, can hallucinate. And so I think that sometimes people look at that as like an equal dichotomy. Like, oh, maybe it could deliver physician level care, or maybe it'll make a mistake here and there. And I think that those things are not equal. I think the potential for AI to come up with a differential, come up with a treatment plan, what would it enable? It would enable us to expand care into places that currently have little to no care.
Welcome to How I Doctor, where we're bringing joy back to medicine. Dr. Karandeep Singh is one of my favorite people to run into at conferences because who he is professionally is entirely different from who he is in person. On paper and at UC San Diego, Dr. Singh is publishing and creating some of the best work in AI and prediction models in medicine. And in person, he is absolutely hilarious and one of the most entertaining people to hear present or strike up a conversation with. Karandeep is a nephrologist, an informaticist, and the inaugural Chief Health AI Officer at UC San Diego Health. Back in 2021, he was publishing research at the University of Michigan that questioned Epic's own sepsis model, showing it only worked about 63% of the time, and that a clinician might have to evaluate 8 separate alerts just to find one case of sepsis. He is really the rare person who's been on both sides of this, exposing a maybe flawed model and now deciding which model gets deployed at all. I'll be right back after these messages from our sponsors. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. The next generation of physician innovators are already thinking hard about AI in clinical practice. Off-Call teamed up with MD+, a nonprofit community of physicians and med students across the country, to write the guide I wish existed when I started trying to make sense of all of this. It's called The Physician's Guide to AI, a practical primer across specialties. 9 specialties, 40 plus physicians, and it's completely free. Search for it now in the Kindle store or visit offcall.com. Dr. Karandeep Singh, welcome to How I Doctor.
Graham, thank you so much for having me and for the kind intro.
You're a practicing nephrologist who also codes. How did you end up as an inaugural Chief Health AI Officer? Was this always a passion of yours? Did you discover it during medicine or residency or fellowship?
So I learned to code, I think, when I was 8. And I think over the course of my career, I've learned something like 14 different programming languages. And the reason I learned to code wasn't because someone told me to. It's because I wanted to solve things that were happening even in my life at that time. At that time, it was entertainment. But later in my life, it was actually problem solving. And I think that was something that never left me. So I think for me, it was like at every point from medical school where I worked on acid-base calculators to residency where I worked on administrative things, even like we had a drip system of admissions when we were trying to pilot. Does it help if you admit in this way rather than in that way? And so I wrote a JavaScript thing that could locally, without sending anything to the web, you give it medical record numbers and it reallocates those amongst teams. And we actually used that in our bed control for some period of time to try to see if that actually helped offload the on-call team onto other teams and what was the actual impact of that. So I think, to me, being able to code was a superpower that allows you to take problems that where, the healthcare side of your brain, which is a little bit jaded, says that's a difficult problem. We can't solve it. And it puts a problem-solving mindset on it that
Yeah.
maybe we can solve it with this way. And so even I think all the way through fellowship and onwards, it wasn't until I was a nephrology fellow that I discovered the field of biomedical informatics as a
Huh.
true field. So I think for me, this was really about, I was doing biomedical informatics for years before I realized that's what it was. And so at that stage, I think the mentorship in that space was quite sparse. A lot of the things that I like about medicine are the same things I like about, AI and nephrology, which is it's a very math-oriented field. It helps you think of problems in a problem-solving mindset, which I think is one of the core features that ultimately led me to go from that to a spot where I was now thinking about how to problem solve with machine learning in a healthcare setting, and then problem solve with a broader set of AI technologies, inclusive of generative and agentic AI.
Well, I love that we're talking. I don't think I knew that level of detail about you. I mean, I was in med school. I was like troubleshooting people's printers because I thought it was fun, and I was like, "Oh, you just need to download a new driver." It was like so. It was also very intuitive to me. So I think part of it was like nature, and part was nurture. That was just like because I grew up with computers, this was obvious that you needed a new Windows driver or something, and
Yeah.
this was pre iPhone and pre Facebook. And so I had made like a little directory service with a PHP server and SQL that you could go in and add your phone number and your address and your AOL Instant Messenger name and your ICQ screen name so that we could all connect with each other as first year med students because we didn't really know how to. And you could even download like a V card to get way too nerdy to import into your old like Nokia phone too.
Very, very similar. I
Yeah.
think I used to write apps for TI-85.
Oh, there you go. Yes.
So I think healthcare, you're thrown in the middle of a system that is already flushed out and, humming on all cylinders. You kind of come in as a new med student, you see things happening all the way from, outpatient to the ER to inpatient to surgery. And you're getting these like little windows into reality for these very different stakeholders, and a little bit shocked by how different it is, both in different systems, in different environments, in different roles. And so I think it's that systems thinking that you try to apply to try to make sense of it all. And I think that's where, when you're in healthcare leadership particularly, you need to develop that skill of trying to look at these windows and make sense of the larger picture of what's not working, why is it the way that it is, and is this fixable, and what's been tried, and why didn't that work, and what's the next thing to try. So I think that's the thinking I wanted really more of in my career around the space of AI. I felt like leading AI governance and setting up AI governance was a really kind of proud achievement to be able to help us as an organization when I was at University of Michigan think through what gets deployed, how it gets deployed, thinking about all the methodologic issues with picking thresholds. So I found the development of the science and the application of the science fascinating. And if we're bringing AI into a healthcare system, you're often changing the way that you do care delivery to be able to make that actually the best possible chance of having a positive impact. So for me, I think that part of it was what ultimately drew me to this role as Chief Health AI Officer, where I really want to make sure we as a health system have AI as a toolbox front and center.
Sometimes I kind of over-index on what people's specialties are, but every nephrologist I've ever known and had the pleasure to work with and consult is always so smart, so dedicated to their patients, and then also just has tremendous sense of ownership and responsibility. And I think those things are what we need from AI leadership as well. Like we need a lot of intelligence around how these models work. And then we need like a responsible person or people that are going to say, hey, here's how we think these things need to work. I'm going to own this. I'm going to be responsible for this as well. You gave such a great talk at the CHI kind of pre-health evolution summit on using AI. I think you guys were using it with colonoscopy reminders.
We are on a journey as an enterprise to look at the use of AI, and specifically agentic AI, to enable automation in places where right now the status quo is not great and where we think the status quo could be better. One of those places was pre-colonoscopy prep calls, where we were relying on our floor nursing team, who are busy taking care of
Busy
patients
human beings.
on the floor. It's not like they're otherwise would be at home. They have a lot to do. And we were tasking them with calling patients who had a colonoscopy coming up the next week to go through an entire script that covered everything from parking to medication hold instructions. But to do that effectively takes at least 5 minutes, potentially 10 minutes, potentially 20 to 30 minutes, depending on how many questions a patient has. We recognize this as an area where I think AI could help, because what happens if patients don't get that preparatory call and get those instructions? Now, they get them in written form, but what happens when you don't reinforce it? You have patients who accidentally don't pick up their bowel prep on time, who take a medication they should have been holding, who have an issue relating to, how to get to their appointment. And then you have people who cancel late. And if a patient cancels late, we can't initiate a bowel prep in time for us to fill that slot. And that creates a cascading effect where that endoscopy suite goes unused for that case. So we identified this as an area where it would potentially improve patient access. We would hopefully can get even fewer cancellations than what we had. And we felt like our status quo had room for improvement. The solution that was proposed was maybe we can have AI call our patients. And if AI can call our patients, it can walk through the majority of that script with them in an interactive way. And then if a patient asks a question the AI can't or shouldn't answer, we'll flag that as an escalation. And then rather than do these long phone calls with patients that cover a lot of ground, we can have nurses that call and do a targeted follow-up call that's really about the reason for escalation. So I think a key thing is, even though we call it AI automation, a substantial amount of the work still gets reviewed to make sure that the recommendation was correct. And if a patient says, hey, I really want to talk to someone, we give them the ability to do that. We've really had positive input from our clinicians. We've had positive input from our nursing teams where they I'd say the ones that we've talked to generally prefer our current workflow over what we had before, because their work is now focused on nursing. It's not focused on parking. It's not focused on all the other parts of that encounter that were not, related to the actual clinical expertise that they have. And yet they are still very involved in the care. So you can imagine from a legal risk compliance, AI governance process, there was a challenging lift to go live in production with something like that. But it really took a reframing of how we do AI governance, a new set of processes to handle agentic and direct-to-patient AI, which involves a failure mode and effect analysis, and a key involvement of stakeholders, where we have gone out and done nursing interviews. We collect patient feedback on every call that we monitor and read every single week. So I think it's something that is not something that you go live with and that you just watch. You have to do a lot of follow-up. AI is just becoming a part of the way that we deliver care. And I would like to think it's still very much human-centered and team member enabled. It is not something where, we have traded off a nurse with a AI.
Yeah.
What it's allowed us to do is actually to reach 100% of our English-speaking patients, whereas previously we were only reaching, a fraction of them. And we still do the old-fashioned calls to non-English-speaking patients because of certain regulatory things, but we have looked at ways in which we may be able to enable this also for non-English-speaking patients.
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. It's interesting. I used to talk about a couple of years ago, we should just do AI for administrative stuff. And then Spencer Dorn, who's at UNC, said, it's actually kind of hard to have a really bright line in the sand that says, oh, this is administrative and this is clinical. Because when you first hear it, you think, they're automating the administrative, quote unquote, task of calling patients. But then you realize there are tremendous clinical impacts to what seems like just an administrative phone call, right? It's like, oh, you either lose an appointment for a colonoscopy, or they have a poor colonoscopy bowel prep, and so the quality of the care is actually lower. It's really interesting that like we want to say, oh, let's just do administrative stuff because that seems like it'll be lower risk, but it's so intertwined. It's hard to separate the two really clearly.
I think periclinical is a really great space for this kind of automation. So places where we want to educate or we want to ascertain how people are doing. So transitions of care, places where we know that there are risks for drop-offs in care to result in things that will have administrative and clinical and operational impacts.
Yeah. Let me maybe just ask you, like, what do you do as a chief health AI officer? Like, are you defining that role? Because it is such a new role. Are you a high level person, governance, vision, strategy, or are you like getting into the weeds of like, hey, here's the workflow that we need to change?
So I think if you asked a dozen chief AI officers this question of what they do, you'd get close to 12 different answers.
Yeah.
My role is better understood if I state what my 3 different roles are.
Okay.
So I'm a chief AI officer for UC San Diego Health. I am executive director of our Joan and Irwin Jacobs Center for Health Innovation. And then I am a tenured associate professor in our division of biomedical informatics in our Department of Medicine. I am a researcher by background. Jacobs Center for Health Innovation, that focuses on implementing new digital health and AI technologies that don't have an established playbook. That can even involve helping us figure out when we build our next hospital, what set of technologies is in the room, how is it laid out, what infrastructure is there that supports the use of that technology. And so within our team, we have a design team that can do everything from user experience, user interface, to actually designing artifacts, working with other key stakeholders. And then we've got folks who do enterprise automation as a routine activity, led by one of our co-directors in our center, which is around building some of these automations like the colonoscopy, pre-op calls, but certainly not limited to that. And we have a dozen use cases on the roadmap for what is happening there and several things that are already live. Separate from that, I have the chief AI officer role where I lead AI governance for the system. And then, I work closely with our chief innovation officer, and with, reporting to our executive team with the support of our chief innovation officer to really make big strategic decisions around what are we doing in the space. So I think if you think about what does an AI leader do, it's evaluation, governance, implementation. And I would say that my role hits on all 3. But what drives me really is what I like to think of it as is that our Jacobs Center is what enables our system to be a learning health system, along with other colleagues like from the Center of Learning Health System Science and other, folks who do research right at the intersection of operations and clinical care.
What I'm hearing is there are a lot of resources required. This is not I just have a ChatGPT account and that's all I need to quote unquote deploy AI. Like, do you think this is a academic medical center resource allocation? Do you think this is what every kind of health system needs, even if they're not trying to publish research? Like, do they all need this level of rigor and detail?
When you make a decision to use AI, and let's just separate out for a moment AI that's integrated already in the electronic health record and comes part and parcel with the electronic health record, and separate AI that you have to make the decision to integrate. So if you're deciding to integrate AI outside of the electronic health record that may integrate into the EHR, you have to make a call on an upfront investment that may not be cheap. And there's almost always an opportunity cost, both financially and for your IT teams, because time they're spending building that integration is time they're not spending doing something else. Every system, whether or not they had a chief AI officer, pretty much went with an AI scribe solution in the last 3 years. So you don't need a chief AI officer to turn on AI scribes. However, I think when you're doing something that's brand new, or things where everyone's doing it, but everyone collectively admits we don't know if it works, if you're making a large investment, that's the place where financially it makes the most sense to have a learning health system. You are incentivized to figure out whether this thing works and how it works and what does it do and what does it not do. Because a year from now, when you have to renew that contract, it'd be great to come with your own data and not simply rely on the data given to you by the vendor to say, look, it's working
Yeah.
great.
Yeah. Yeah. I like that idea of coming with your own analysis and metrics because you're not as reliant on what the vendor is telling you about your physician's usage of a tool, for example.
Yeah, usage is great, but usage isn't a helpful early marker, right? If you look at implementation science frameworks, reach and adoption are some of the things that you want to look at. So
Yeah.
if people are using something, that is a great positive signal that something is there. I think the next question becomes, well, is it worth X dollars that we're spending on it? That's where it really helps to understand when you look at the quintuple aims, what are we actually achieving of those? And how much is it moving the needle? And a lot of times you think it's moving the needle, it's not.
Karen, I know you mostly, well, I know you almost exclusively from your AI work in the past couple of years, but I mean, it really wasn't until we were doing background research that I was like, oh, he, he's the one that did the epic sepsis publication. I mean, that was just so amazing. Where did that interest come from?
Yeah. So one thing I should point out is that when I finished fellowship and went to University of Michigan, I joined the Department of Learning Health Sciences, which is an entire department dedicated to studying learning health systems. And so I was actually not housed in my clinical home department. I saw patients clinically, and
Oh, wow.
I had a joint appointment in nephrology, but my primary academic appointment was in learning health sciences. Most of my colleagues and my department chair were PhDs. And so I was one of I think, the only core faculty who was an MD in this department. And so my interest really from the get-go was use of AI to enable learning health systems.
That's cool.
And early in that role as a researcher in that space, I got invited to help co-launch our health AI governance at University of Michigan in the health system. And I said, I don't know how much service responsibility I should have early in my career when I should be doing research, but the actual science I care about is the science of implementing AI at the health system. So I've got to do this.
Yeah.
And so then I think it was actually in our implementation of that sepsis model that we got an early signal from 2 units where we had implemented it that, hey, the tool is working differently than we thought it was based on the numbers. And anytime I get qualitative feedback, I have found that the math almost always backs it up. And anytime there's a discordance between your qualitative feedback and the numbers, most of the time your numbers are wrong or your math is wrong.
Yeah. I think that's what Bezos even says. Like when you're not sure if your Excel spreadsheet's right and it doesn't meet, essentially it doesn't meet face validity, that you actually like, hey, yeah, the human being has an experience that actually has significant value here too.
Yeah. So we took that really seriously and we said, well, if something is off, how do you currently measure sepsis quality? And they said, well, we have these internal timestamps that we use operationally. And what we're finding is the tool is great at case finding cases after the fact. It doesn't seem to be great at predicting it before it happens. And I will honestly be the first one to say, a sepsis model does not need to predict sepsis before it happens. It's fine for it to predict it afterwards. But if you look in the model card for this model, the original model card said, this predicts sepsis before it happens. I get why it said that, but I think that that's where, I kind of brought my methodology hat and said, well, if we're going to be AI governance, we're going to do it properly. And for something as high impact as a sepsis model that is deployed nationally, which we are just thinking of turning on, let's at least understand the alert volume it will create, how much of the work that it creates will actually be good work and helpful work versus not. And there's a lot of decisions that go into that. But we said, we'll start with most of the vendor provided recommendations on where we set our threshold. And then let's look at that and see, at that threshold, could we actually deal with the level of accuracy that's there? I think the researcher mentors in my life at that point said, this is not a fruitful direction to go in because validating other people's models was not something that people generally could get published in journals.
Yeah.
Usually you had to develop it and validate it.
Yep.
So I think I said, I don't care. I think this is actually the central question that health systems should be thinking about. And I think we dove right into it and did it. And we didn't do it in kind of a sideways way. We did it as a core part of our health AI governance. So I think it was not like a one-off. We did that kind of evaluation for many, many models, but I think that was one of the ones that we ultimately ended up publishing because it was one of the earlier ones that we did, and one of the ones that I think, from my standpoint, had the most relevance to other systems, even though we had only done it in our system, which we then later went to follow up and do. We recreated that same evaluation for other systems as well.
In the same way that we were talking about, there's overlap between administrative work and clinical work. This is also a way where you start to see an overlap between clinical work, clinical impact, and informatics, user interface, UX, user experience. Like, to your point of, if the physician has to go through 8 soft stops or hard stops, we know that human beings stop paying attention eventually. The hard stop starts to be just glossed by, and that's actually how you can create harm in medicine too.
And predictive AI generally creates work. So, right, both predictive AI and generative AI are ways to reallocate care when you have resources, or resource constraints, rather.
Yeah.
So with predictive AI, you are identifying high-risk patients that you are going to spend disproportionate time on, where you spend less time on other patients to try to level the playing field. That's the idea with things like the sepsis model. You're in the room of the patients who are on the border of having sepsis because those are some of the sicker patients. Same thing would be applied for deterioration models and models that ilk in the hospital. On the flip side, most generative and agentic AI things, they are trying to reduce the amount of work by offloading certain amounts of work and trying to automate aspects of the work. And then the humans get involved in just the escalation part of the pathway. And there you often can reach more patients, like everyone can get evaluated to some extent, but then only a certain number of patients are going to meet the criteria for escalation. So I think in both cases, you have to be mindful of what is the work that you're creating, and is that work viewed as valuable? The biggest challenge, I think, with sepsis models is that for the best published literature for sepsis and deterioration, the absolute risk reduction for mortality is about 2% for the use of these models. Not the relative risk, but the absolute risk reduction. So if you ask a clinician, do you feel like it's working? I would challenge you to say most of them will say no, because you can't inherently feel a 2% absolute risk
1
reduction.
in 50, yeah.
Like you'd have to care for so many patients and see it work. So I think that's where a lot of the challenges is with predictive AI, is that you can't inherently see the benefit, even when the math later then bears it out, because it's a small enough benefit that's clinically valuable and equates to lives saved, but also equates to additional work. And people are much more likely to remember the more frequent occurrence of additional work than they are to remember the 1 or 2 cases in the last 50 where a life was saved.
That's a great analogy. It's like, I think the NNT for aspirin for STEMI is like 1 in 34 or 36. It's like I have to see 36 STEMIs a year and give aspirin to every single one, and maybe I have a dent in the mortality of one of them, which it doesn't feel as good as like giving Zofran to somebody who's puking and they're like, "Oh my God, I feel so much better."
Whereas the time savings for generative AI, where it's used as in a human in the loop way, is often noticeable. It's maybe not the hours that we thought it was on average, but 20 minutes saved per day is still noticeable. And so I think that's where it's still very much a tool that people can feel the impacts of. In predictive AI, the impacts are hard to feel because the outcomes we're trying to drive are often longer term outcomes.
Do you think we should go faster or slower, or is that the wrong way to think of this? I mean, if you were magically in charge of all of medicine or healthcare, like, what's the right speed or the right approach to decide, hey, this tool, this model, this approach is ready for widespread application in medicine versus, hey, we need to slow down on this one? How do you even think about deciding that?
Yeah, I think the biggest cognitive dissonance right now is that at the same time that you've got papers published that show that AI can have superhuman physician performance on taking histories and, coming up with differential diagnoses and coming up with treatment plans, you also have literature that shows AI, even the most advanced, can hallucinate. And so I think that sometimes people look at that as like an equal dichotomy. Like, oh, maybe it could deliver physician level care, or maybe it'll make a mistake here and there. And I think that those things are not equal. I think the potential for AI to come up with a differential, come up with a treatment plan, what would it enable? It would enable us to expand care into places that currently have little to no care. So I think you have to step back and not look at this from a health system perspective, but from a national population level perspective. And nationally, we have major shortages of care in all kinds of different places. And I think while you can't just say we need to make AI-based care like legal off the bat, I do think we need regulatory sandboxes to try new models of care that currently aren't legal today, but that would allow us to generate the science in a relatively safe manner, in a graded fashion, where you start with low-hanging fruit and you move progressively towards, things that are more and more difficult. You're already starting to see this happen organically. It's happening in Utah with medication refill prescribing. It's going to happen with the ARPA-H advocate program,
Yep.
and what the aims of that program are. I will point out there are some areas where we need policy changes. A key one is you currently can't have AI do machine translation from English to other languages.
Yes. Title VI of the Office of the Civil Rights. Yeah.
Anywhere where accuracy is essential, it's written into the ACA, and there's an Office of Civil Rights letter on it. I'm not proposing we replace interpreters at all.
Yeah.
What I'm proposing is we have plenty of places where the current standard of care is you just message people in English, a secure message, they translate it using their translation tool of choice, and then they translate it back, and then you are kind of benevolently unaware,
Yes.
blissfully ignorant of the fact that your patients are using the translation tools.
I had no idea. Yeah.
So I think those are some of the places where we really need to look at. We live in a country that's diverse, where people speak different languages. What can we do to test that kind of interaction in a regulatory sandbox, not behind patients' backs, with patient engagement, consent, and involvement? Because I think some of the science now is outpacing what's actually legally allowed. And what I will say is there's other countries where you can go to the pharmacy and just pick up antibiotics. You can just pick up things that are in the US are kind of kept very carefully behind the medical kind of, I don't want to say establishment, but between requires a doctor and a pharmacist to release that to you. I think that, those are opportunities where culturally we started from a place of extreme caution, and we should look at, I think, what are ways in which we can still do that level of caution or close to that level of caution, but do it in a scalable way that frees up our physicians to be able to see patients, which improves healthcare access, which really reframes the system so that we put the people where they're needed most, and we try to handle some of the other stuff with AI. And if we don't have a regulatory pathway to test those models of care, I think we're not going to make progress and we're going to get stuck.
When someone is trying to decide if they need to go to the ER for a broken toe, their options are literally nothing, or, a Google search, or generative AI, or maybe they can call an advice line if they have insurance and they can wait 30 minutes to answer the question. And then they may still say, hey, CYA, if you're worried, you should go to the ER. And it's like, well, I think we should inform patients and let them have some choice in the matter and some information, and say, hey, if it's your big toe, yeah, actually maybe, because the big toe is the only toe that is kind of important. And if it's your pinky toe and you stubbed your toe and it's black and blue, the ER is not going to do anything besides teach you how to buddy wrap and buddy tape your toe, and AI can teach you how to buddy tape your toe too. So
we have such differentiated physicians in the US who are so expert in their various areas that you also see a lot of, I think, interphysician work created by the fact that I, as a nephrologist, don't know that.
Oh, interesting. Yes.
Right? And so you might come to me and I might send you to the ER. So I actually think another place to really intervene, and I think we're going to see this with AI Scribe. I think my prediction is with AI Scribes, they're going to provide clinical decision support in real time that tells you, hey, I know you just said this. You probably want to think about doing this instead. And I think there's going to be a moment where after the visit's over, you pause, you look at actually what those recommendations are, and you deliver those in real time to patients before that encounter ends. Because I think that is really the next phase of decision support, is in the room decision support based on what you already talked about.
I love that. I love that idea. That's great. Dr. Singh, it has been an absolute pleasure to talk to you. Where is the best place to find you, the work you do with UC San Diego Health?
Yeah, so I think for our Jacobs Center for Health Innovation, our website is healthinnovation.ucsd.edu. If you want to look at what work we're doing in the space of AI broadly, it's health.ucsd.edu/AI. And you can find me on LinkedIn and Blue Sky.
Amazing. Thank you so much for being here. It's been an absolute pleasure. It's great to get to see you again.
Thanks, Graham. Likewise.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.